This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program to those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce Dr. Peter Byers, our speaker for this evening, and then we'll have a Q&A session. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter Deanna leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 65 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback from the conferences that they provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All of the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You will receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program and usually covers our monthly web fees. So please visit our store and check out the helpful products we sell. We can still deliver before Christmas if you get the order in real fast. So just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911 and get the services you need. Always consult your doctor before making any changes to your treatment.
Wanted to let you know about some upcoming events. The next webinar will be Tuesday, January 6th, and our presenter will be Dr. Henry Burkholder. He's a pediatric cardiologist who's going to speak about POTS and EDS. Dr. Burkholder was a presenter at the EDNF conference that was held in Houston this past summer. And again, just to let you know that our webinars will be on Tuesdays in 2015, on the first and third Tuesday of each month at 7:30 p.m. Eastern Time. And for those attending live tonight, there will be an opportunity for Q&A after the presentation. Please add your questions at any time during the presentation by clicking on the Q&A icon located at the top of your screen. After typing your question, click the orange button to submit. I'm pleased to announce our speaker tonight, Dr. Peter Byers. He is the director of the Collagen Diagnostic Laboratory at the University of Washington, and his lab is the primary source of diagnostic testing for Ehlers-Danlos. He's going to talk about vascular EDS tonight, and also will be willing to answer your questions related to testing and classical EDS as well. Dr. Byers is a professor of medicine and pathology and adjunct professor of genome sciences at the University of Washington, and he's board certified in clinical genetics as well as internal medicine. As I mentioned, he's the director of the Collagen Diagnostic Lab, and the lab offers diagnostic testing for several forms of EDS and also for OI and other connective tissue disorders. They will provide consultation for clinicians and families with questions on these rare disorders. They'll review x-rays and clinical history and also offer research testing and enrollment in research studies. Dr. Byers' background is that he's a graduate of Case Western Reserve University, and he had his internship and residency at the University of California and his fellowship at the University of Washington. His research interests include molecular pathogenesis of inherited disorders of connective tissue, and focuses on disorders that affect collagen genes and enzymes involved with the post-translational modification of collagen. Also want to note that Dr. Byers is the 2008 recipient of the March of Dimes Colonel Harlan Sanders Award for Lifetime Achievement in the field of genetic sciences. So we want to congratulate him for that. So with that, welcome, Dr. Byers. We're looking forward to your presentation, and we're going to go ahead and load your slides now. And I'm going to turn the microphone over to you.
Thank you very much, Deanna and John. It's a pleasure to be here. It brings me back to my teenage years of lying on the couch and talking on the phone, hoping that there would be a response from the audience. I'm hoping that we will get some responses out there. It's a pleasure. As Deanna said, I'm, in addition to directing a laboratory here, I'm also a clinical geneticist. We see families in our clinic here in Seattle at the University of Washington. We do a lot of testing, as you know, and I've seen a few familiar names pop up on the connection thing. So to those of you who we've studied and those of you who we know, it's a pleasure to have you on board, and hope that this proves to be interesting. We have two separate peer groups, EDS peer groups here in Seattle. One which is primarily people who have hypermobility that Mitzi Murray and I direct, and we see people about every 3 to 4 months there. The group is headed locally, and it's really a consequence of very good leadership that that group has stayed together. We have a second group which is devoted to people who have the vascular form of EDS. That we've met with and enjoy seeing them, and we have people who've come from throughout the state of Washington and also from Oregon here, and we're in the midst of planning a new session. So for those of you who live in our neck of the woods, including as far away as Portland or Salem, and north into British Columbia, we'd be delighted to see you here. So the talk tonight is devoted specifically to this one uncommon form of Ehlers-Danlos syndrome, previously called Ehlers-Danlos syndrome type 4 and currently called Ehlers-Danlos syndrome. It's uncommon. How uncommon is it? How many people do we think there are? Well, we've studied more than 1,200 people with it in our laboratory, and we know that there are many other people who've been studied other places around the country. Our estimates are that we think that this probably affects about 1 in 50,000 people in the country, which would mean that we have somewhere on the order of 6,000 people in the country who have this. So we think we've studied almost a fifth of all the people that are available in the country. Our studies, as you'll see, give us a lot of information about the condition, about the natural history, about what happens to people over time. And our experience locally with people gives us experience with the person-to-person interactions with people. And there is nothing like sitting in a room and talking with somebody and with a family with this disorder to really give us a much clearer picture of what it feels like to people, what the concerns are, and what's going on, and what kinds of things we really ought to be doing. I'll come short outline of where I think we're going to go and leave plenty of time for questions. So the first is a short historical tour of where we are, what nomenclature is, why is it called what it is, a current definition, our diagnostic tests, the natural history, some issues about pregnancy, which is a very special issue in this disorder and has had a long history of problems, the issues around assessment and surveillance, questions about treatment, and then at the end I want to come back to this question about, I have a little bit of vascular and some hypermobility EDS to try and resolve how do we deal with that and what does that mean from a geneticist's point of view. So I have to warn you, I am a geneticist, which means that I trained here at the University of Washington, which has long been one of the major sites for genetic studies and genetics, and take a particularly genetic perspective on what happens, which means I'm interested in what the genes are that are involved in disorders, what kinds of changes occur in the genes, how do we identify them, what the differences in different genes mean in terms of what the history is going to be for people, how do we make the diagnoses, and what is it that we need to do. So if it gets too technical, just write a little note up there and saying this is far too technical. Let's back off a little bit. But I'm hoping that our experience in talking with people in our clinic will give us at least some sense of making this more or less understandable to most people. Otherwise, it will be one of these very long nights for all of us. So the Ehlers-Danlos Syndrome is named after two physicians, Ehlers and Danlos, who identified people at the end of the 19th century and the beginning of the 20th century. One was Danish, the other was French. You can probably guess that it was Danlos who was French. And identified people who had soft and doughy and stretchable skin with easy bruising. And when a condition is identified and then given a name, the name was proposed for this group of people in the 1930s. It's often picked up and used when there are people who have similarities. And a German physician, George Sack, identified a set of people who had a defect which gave rise to increased risk for vascular rupture. And the identification and then the beginning of classification really fell first to Anthony Barabbas, who is a surgeon in Britain, and then Peter Byton, a geneticist who was British but who worked in South Africa and Britain. And together they began to see people who fell into this condition or were thought to have something like it and recognized that there was a subset of people who Barabbas then wrote this letter, which appeared in the British Journal of Medicine in 1967 or 69, I think. And he said, I propose that until the basic defect is discovered, this condition, which has now been described clinically, should be given the name of the person who first described it. And remember that many disorders were characterized or called by the name of the person who first wrote a description of it. Marfan syndrome, after Professor Marfan, and so forth and so on. And he said that the Sack syndrome, instead of the arterial, ecchymotic, or dysvascular type of Ehlers-Danlos syndrome, would emphasize the enormous difference in prognosis between this disorder and other types of the Ehlers-Danlos syndrome. Indeed, despite some overlap in the clinical features, which is not unusual in inherited connective tissue syndromes, the Sack syndrome is clearly distinct from the Ehlers-Danlos syndrome and should not be grouped with it any longer. So this is a radical notion, and I think it still has some value to it. But historically, it really has been grouped with the people who have other forms of Ehlers-Danlos syndrome. And I think that it's given rise to some of the concerns, and we'll come back to that at the end again, about whether you can have some EDS4 or vascular EDS, as well as having other forms of Ehlers-Danlos syndrome, or whether Ehlers-Danlos syndrome, vascular Ehlers-Danlos syndrome, is really a distinct entity. And the answer is it is really a distinct entity, but there's an awful lot of variation within it. You'll see that as we go along. So the classification was dealt with, and as people saw more individuals with features that had often joint hypermobility, had easy bruising, unusual skin, but it was recognized that there were people who fell into different groups and could be described as having Ehlers-Danlos syndrome. And in the late 1990s, a group of people met and created a classification which is presented in this table from the work of the Villefranche group that met in a very nice place in France to discuss their clinical impressions. And it included Peter Byton, who had previously created a numerical classification. So the numerical classification is contained in the middle, and there's a new classification which is descriptive. And it said, here are the problems that are the major ones that are facing. Let's call these, instead of having numbers for them, let's call them by their major problems. So the classical type, which used to be called the gravis and mitis type, was one where people had hypermobility, soft skin, easy bruising, and quite hypermobile joints. There was another group that was quite common, which was hypermobility, and I think for many people that's now one of the leading hallmarks of Ehlers-Danlos syndrome. There was a distinctive group, which was called now the vascular type instead of the arterial or ecchymotic or sac-parabus variety, previously EDS4. The kyphoscoliotic type, which was EDS6, and you'll notice that EDS5 is missing because there was no good support for it. You can see it down at the bottom, X-linked EDS. It's never been resolved, hasn't been solved, and people are not sure that it exists. It may be a special form. And so there were other forms of that kind, and that's led to an even more extensive classification as time has gone on. Now, at the time that this occurred, they made an effort to try to create clinically based ways of making the diagnosis. And they did that because not everybody had access to genetic tests. Genetic tests were in their infancy at that point. There were protein-based tests that involved taking a small skin biopsy, growing cells from it, and looking at the molecules that were made by the cells and using that to make a diagnosis. And they were good, but they were not 100%. So in that paper, you can see here is a portion of it I've taken out, is the definition of the vascular type. So it's caused by structural defects in the pro-alpha-1 type 3 chains, that's how that's read, of collagen type 3, which is encoded by a gene, and the gene name is col3A1. So col is collagen, 3 is type 3 collagen, A1 means alpha-1 chains. It's inherited in an autosomal dominant fashion. Well, what does that mean? Well, that means that it's inherited from parent to child and can go through many generations. It can be new because it affects one copy of the gene, and can, as a consequence, people with this can be born to people who are unaffected. And in fact, in our experience, almost half the people that we study and half the people that we see here represent the first person in the family. So trying to use the clinical features that were present and that we're seeing, the characteristics included thin, translucent skin. So the skin was thin, and the translucent part meant that you could see blood vessels much more easily than in other people. There was often extensive bruising that didn't have an explanation. A characteristic facial appearance, which you can see in the woman who's in the picture. And major complications, which included arterial and intestinal rupture or fragility, and uterine rupture during pregnancy. Now, in addition, there were a number of other things that were noted, which included acrojuria. I'll show you a picture of that in a minute. Acro means the tip or the ends. The heights, if your fear of heights is acrophobia, but it means the ends or so the ends in this case of limbs. And juria is aging, So it means distal aging, or it means that your hands and your fingers may look quite old. Hypermobility, which was usually limited or could be limited to small joints. In some people, there were tendon and muscle ruptures. A number of people, and now it turns out to be about 5 to 7%, were born with club foot. In some people, there was early onset varicose veins. There was a particularly unusual feature, which was called a carotid cavernous sinus fistula. And this was a communication between the carotid artery inside the skull and a venous fistula, or a venous cavern that was there. And the consequence of that was that there was backwards flow in the veins draining the eye that pushed the eye forward and interfered with vision. Some people had pneumothorax, which is spontaneous rupture of a small portion of the lung, and so there may be lung collapse. Some people had gingival recession, which means that their gums receded. And in some, there was a positive family history of sudden death in a close relative. A close relative is the parent, sometimes a sibling, occasionally a grandparent. And so this was the description that was used, and it gave the illusion that this was a very easy to diagnose disorder, that anybody could do it simply by looking at the picture. And this is a numerical classification of Ehlers-Danlos, a more modern one, a more extensive one. And you can see now, more than 15 years after that classification, we've been able to add the gene names and the genes that are causative, that have causative mutations. Both the classical variety, it's type 5 collagen genes, called 5A1 and called 5A2. For hypermobility, we don't know the genes that are involved for most of them. Occasional mutations here and a few other mutations in other genes. But for the vascular gene, one of the vascular form of Ehlers-Danlos syndrome, one of the defining features is that people have mutations in the COL3A1 gene. The type 6, there are two genes, PLOD1, which is lysyl hydroxylase an enzyme, and this other gene, CHST14. And you'll notice that the inheritance for the first several of them is AD, which means autosomal dominant, which means that it transmits through families, and for autosomal recessive, it's SIBSHIPs that are affected, so brothers and sisters. And then there are these other disorders that are present as well. And that this list has actually been extended substantially so that there are other ones that now don't have a former name or a former number, and they're being defined because the genes that are involved in them are actually being defined. So the clinical features that are required or expected for a diagnosis for Ehlers-Danlos type 4, the vascular ecchymotic means bruising type, are easy bruising, thin skin, apparent venous pattern, arterial rupture, bowel rupture, uterine rupture in pregnancy, and joint hypermobility, which is often limited to small joints. It should be easy. That sounds like it's a very easy diagnosis to make. Some of these are historical. You have to have had an arterial rupture or a bowel rupture or a uterine rupture for that to be part of the criteria for making the diagnosis. Here is what's meant by autosomal dominant inheritance. Here's a woman who died at age 34 of uterine rupture in the course of the pregnancy of her youngest daughter. Her son died at age 35 of a bowel rupture and consequent sepsis. But you notice that she also had two unaffected children. The reason for that is that she has one altered copy of the gene and one copy of the gene that's actually perfectly fine. Her husband, who's unaffected, has two copies of the COL3A1 gene that are perfectly fine. When we have children, we transmit only one of each copy of the gene, and so she has a 50% chance to transmit the altered copy of the gene and 50% chance for each pregnancy to transmit the unaltered copy of the gene. So you can see she's got one affected and two unaffected children, which is perfectly within the range of what you expect. Her son then has an affected daughter and an unaffected daughter, and the affected daughter has had one child who, by the time she was pregnant, we were able to do prenatal testing and recognize that this pregnancy was unaffected. So this is another feature which is available to people in the course of pregnancy if they decide they would like to have an unaffected child. There are other alternatives as well we can talk about if you want to do that later. So the idea that this is a clinical diagnosis that you can make is borne about by the picture that you saw first. And then here are a couple of other pictures taken from a publication by Shireen Shaloub that was published this year in the Journal of Vascular Surgery. And here are 4 people on the left. And you can recognize that there's something a little different about the upper 2. Dark circles around the eyes. They seem to be a little bit sunken. The lips appear thin. But you might not pick them out of a crowd. And then certainly for the lower 2, then I don't think I would be able to make a diagnosis of EDS4 or vascular EDS walking in the door if these are the people that I saw. And I think this is one of the things that we recognize. In genetics, we often see the most severely affected and most dramatically affected people early on, use that to establish diagnostic criteria, and then get lost later because we don't recognize these conditions all the time. The upper right-hand picture here shows the readily visible venous pattern. So these are small veins that are under the skin. The skin is both a little thin but also translucent. You remember we talked about acrogyria, or distal aging, or aging of the extremities. Here are hands from a 26-year-old woman. And they certainly look like they're from somebody who's much older. And she had Ehlers-Danlos Syndrome. She was one of the first people that we saw in this area with the disorder. And here's a picture of, this is a gathering in Denmark of the Danish group, the EDS group. And I think you can look at this picture and see, and you can pick out for yourself which are the family members and which are the affected people in this group, and you can decide whether you're good as a diagnostician or whether you're as good as the rest of us. So what happened consequence to creating a clinical set of criteria for making the diagnosis was the addition of the necessity to have a mutation in the COL3A1 to fall into this group. And that's because clinically, as other genes were identified and other disorders were identified, it became clear that there was clinical overlap. There was overlap with a condition called Loeys-Dietz syndrome, where people had thin-appearing skin, bruised easily, had vascular problems, and even had uterine rupture during pregnancy. And so it required having a mutation in the COL3A1 gene, the type 3 collagen gene, to actually have vascular Ehlers-Danlos syndrome. And that's important because the clinical course is different for people with mutations in different genes. So what is the clinical course? How do you figure this out? By 2000, we had studied a little over 200 people, 200 probands, that is the first identified person in a family, and an equal number of their relatives. And Melanie Pepin, who's a genetic counselor in our group, assembled all the data along from these people, and we're looking at 2 different kinds of things. We were aware that we had people that died at a younger age, and we wanted to know how that played out in the population. And we were aware that people had complications that included vascular rupture or bowel rupture that may occur, and we wanted to know when those occurred. So the complication graph is the one on the bottom, and across the bottom is the age of people that we know about. And up the left-hand portion is the proportion of people who had a first complication by that age. So if you look at age 10, there are very few people, about 5% of all the people in the population that had a complication by age 10. By age 20, you can go up and you can see that just about a quarter of people had had a complication. by age 40, out about here, almost 80% of people had had something happen. But there were people who continued out beyond here for 40, 50, 60, and so forth, who never actually had complications in the time that we were following them. Now, those complications, the major ones that we counted, were all vascular problems, or uterine rupture, or GI rupture. And those contributed in some instances to early death. So this top open line that the cursor is following here is the survival curve for the U.S. population, and what we recognize is that people in the affected group actually had a shorter survival time, and from this we could estimate that the age at which about half people were no longer surviving was somewhere in the late 40s or early 50s here. So this was our study in 2000, and we continued to accumulate data until very recently, and there's a new publication that's I'll talk about in a minute. So we were interested in, are the people who have GI problems, that is, when they rupture their colon, are they a different group of people than the people who initially have an arterial rupture or a uterine rupture? And so we did a very simple study, which was to say, well, let's look at the people with the first complication, and we'll look at all those people who've had a GI problem. So those are the ones in the dark portion of the circle here. And we'll look at all the people who've had an arterial complication and follow them until they've had a second complication and ask whether or not the proportions are the same. So what you can see is that of the complications in these 220 index people that we had, almost just less than half of them had had an arterial complication, and about a fifth of them had had a GI complication. And when we got to their second complication, you could see that the proportions of arterial or GI complications were almost exactly the same, regardless of whether their first complication had been arterial or GI. So it meant that these are not two different populations of people. It's just that the order in which things happen may be different. And about a quarter of people in the group as a whole had GI complications. And one of the issues in renaming this condition from Ehlers-Danlos Syndrome type 4, which is agnostic in a sense, it really doesn't say what the general complications are, to the vascular form of EDS, makes it necessary to remember that there are more complications than just the arterial tree that are involved. And in fact, we had thought for a while that this may change the way in which we saw people, that they may be referred to us only if they have vascular complications. But the idea out in the community was wide enough spread so that we were continuing to see people that were identified, young people who were identified as having bowel ruptures. And almost all of them have a rupture of the sigmoid colon, which is almost the last part of the colon, just before the rectum. The causes of death in people were almost the vast majority of them were due to arterial tears, but there were a few people who had uterine rupture, a couple of people who'd had the muscle of the heart following an infarct had ruptured, and then liver and spleen. Most people who had GI rupture didn't die as a consequence of it, and they were treated in a conservative way and usually did very well. The arterial events, and this is taken from a paper in the Journal of Vascular Surgery from 2005. I took it from this because our data are similar, but the picture was so nice. And you could get a graphical representation of where things happen. So the carotids could be involved. Those are the arteries that go to your brain. The arteries that go out to the arms can be involved, the subclavian arteries. The aorta can be involved, the descending aorta, the splenic and the hepatic arteries can be involved, the renal arteries, the lower portion of the aorta, the iliacs, the femoral arteries, the popliteal arteries, the tibial arteries. So all of them can be involved. The majority of involvement is in the abdomen and in the chest that occur over time. Now, what does this mean in terms of management, and what's the strategy, and how do we do things? Well, I first have to say that there is no consensus on the evaluation and the management across multiple groups or even across different countries. Remember, we're actually a very large country. We're 3,000 miles from those of you who are in Boston, and about the same as those of you who are in Miami. There are no European countries that are that large. We have a very diverse medical care system that's dominated by private insurers, and private insurers may or may not insure people in the same family, and so the idea of having a whole families involved can be very difficult unless we have highly specialized centers for care. And even then, it's difficult, and we don't have a long history of having those, except for people with cancer. And for cancer, we've done very well. For disorders like Marfan syndrome, like Ehlers-Danlos type 4, Vascular Ehlers-Danlos Syndrome, we don't have the past history of getting people to major centers. We've tried hard to do it. We've been able to do it from a diagnostic perspective, but not necessarily from a clinical perspective where we've been able to see everybody together. So there's no consensus that's developed here. In France, everybody who has the diagnosis of EDS once a year goes to Paris. Now, maybe we should do that every time we have a diagnosis once a year we should go to Paris. Or we should go to Seattle, or we should go to Baltimore, or we should go to Mayo Clinic, or we should go somewhere. Or we should have a few places around the country that where we see people and are able to see them again and again and be able to follow them. Failing that, we need to do a better job in trying to accumulate data on as many people as we can so that we have a better idea about what to do. So the management strategy that's here is developed from this paper by Chu, which includes Hal Dietz from this is the Johns Hopkins group. And what they've recommended is baseline imaging, which is echocardiography, a CT angiogram or an MRI angiogram of the head, neck, chest, abdomen, and pelvis. That's a lot of time in the machine if it's an MRI. Follow-up imaging, as they say, there's no consensus for the follow-up interval. And in some places it depends on what the initial findings were. So if there's a finding of an abnormal vessel, then that's often followed up. And one of the issues about this is that although there may be abnormal vessels, they may not be the vessels that tear or rupture or dissect. And so the presence of the abnormality is not always the indication of where things are going to happen. Surgical intervention, a conservative approach. The thing that's really changed that has been the introduction of what's called endovascular stenting. And that is basically putting a small tube up through the artery to the area that's abnormal and bridging the abnormal area with a tube that now takes the pressure off the outside and makes it less likely to rupture. It's been very effective in some areas. There have been some problems with it in others. The medical therapy here is recommended as a beta blocker, which is an antihypertensive drug or a blood pressure lowering drug. Again, there's no consensus, and many people in many places, certainly the effort is to maintain blood pressure in a normal range, but there's no agreement on what to do. In France, they've treated people with a single beta blocker called celiprolol on the basis of a trial they did there, but the trial is badly flawed, and I'll show you a little bit about that in a moment. You can see that people have, so this area is an enlargement or an aneurysm. You can see here's a carotid aneurysm. This is the carotid artery that comes up from the aorta and goes up, and this section will ultimately go up through here to the brain. There's a very large aneurysm there, and here are other large aneurysms and tears in the vessel, which are represented by this thin line, or that's a dissection. So these are ways of doing things, and the issue becomes what's the approach to it. And many different approaches have been taken. People are wary about surgery because these vessels are known to be fragile. this is the paper from the French group using celiprolol. I'm sorry, it's a little out of focus, you can see, so I'll read it through you, read through it with you. They took 53 individuals that they defined as having vascular EDS by clinical criteria. About halfway through the study, they were finished doing mutation analysis, and of those 53 in whom they had made a clinical diagnosis, only 33 had mutations. They had previously allocated them to studies with celiprolol, the beta blocker. In that group, 13 had mutations, 11 did not. In the 28 that were allocated to no treatment, 20 had mutations and 7 did not. In the untreated group or the control group, there were 3 deaths. In the treated group, there was 1 death. This is not very different. The pattern in which the complications emerged is slightly different, but didn't really reach statistical significance. With this small group, it couldn't have. And you can see that the problems with allocation into the groups is a problem, and so this study remains flawed. But the French group use it. They continue to have problems. The people continue to have problems. So we haven't seen a follow-up study from them yet, but we look forward to it. So the majority of mutations in the gene, we've now identified about 600 of them. About 2/3 of them do a particular kind of substitution, so they make a protein that is abnormal. About 1/4 of them are abnormal in involving the way the RNA is made from the gene. And there's a very small group of null mutations, and that is ones where one copy of the gene is essentially turned off. This is very interesting to us because in other conditions, about half the mutations are actually this type. So we think that this is a group of people that has mutations in the COL3A1 gene, but just doesn't come to clinical attention. And they actually have a different survival curve. They look different. So this is a complicated curve, but this upper curve, the dark one, represents the survival of people who have this particular kind of mutation. And this lower, darker curve through here, the lighter curves around each one are just the limits of variation that we look at, have a quite different population, survival curve. And you can see that these people don't reach the 50% point even by age 65 or so here, whereas these people reach the 50% point somewhere at about 50. So although they have mutations in the same gene, the type of mutation they have, and that is as a consequence of these mutations, people make half the amount of type 3 collagen, but what they make is perfectly normal, as opposed to the other type, where almost all the molecules they make, because of a quirk in the way molecules, the chains get together for the molecules, are abnormal. And those two different kinds of things make a big difference in what people can expect and the kinds of problems people can expect. So this is one of the reasons that diagnostic studies are important to help us understand where things work. Here's a graph taken from the same paper. This was done by Drew Leistritz, who's one of our genetic counselors. If you look at the curve of the dark ones, these are the number of people at any given age. And you can see that the dark ones extend out here. The light ones have a peak that's over here. The light ones have mutations that affect the structure of the protein. The dark ones affect the amount of the protein. So you can see there's a very different survival for the people who have less, but it's normal, as opposed to people who make the normal amount, but it's an abnormal protein. And this is typical of many different genetic disorders that we study. I think this one is a little bit hard to read. It's taken directly from the paper, and this is the real size. But it's it's here to emphasize another one of the features, and that is that half of the people who have that class of mutation, that is, who make only half the amount of protein, have no minor clinical features of EDS, of vascular EDS. I mean, there's half of them have them, but this is very different than what we see in the rest of the population. Now, there's another feature about survival in EDS, and this is something that we became very aware of in the early days of the EDS Foundation, the EDS National Foundation, where a group of mothers attended the meetings, and they attended the meetings because they had had teenage sons that died. And they were emphatic that there is a population, that there's something different about boys, and particularly about teenage boys, and that they are in much greater likelihood of having problems. So we listened, and we heard this. And at the first chance that we had, when we had enough people, we began to look. So these are data from a publication that is actually just in print this month. It was published online about 4 or 5 months ago. And here again, this is the U.S. general population. Women, this is the mean for all people in the center. Women are on have a longer lifetime, and for those of you who are women who are listening in, certainly you all know that that's true. And the same is true here. So here are the boys, and here are the girls or the women. Here's the mean. And what you see is that the boys begin to fall off the curve earlier. It's not true in the general population. In the general population, the early male or the premature ill male deaths are starting at around 35 or 40. But in this group, they're starting in the teenage years, and you can see the difference in the lines. And if you look at the number of deaths by decade in males and females, which is down here, you can see the significant increase. The males are the darker ones here, a significant increase in male deaths early on, and then they even out as age goes on. So that observation by the mothers of teenage boys that had died, it can be verified by the data that we have doing these population studies. And it's one of the things that's very important, and that is that you are asking the questions. That is, the families, people in the families, are asking the questions that are very important to us. And we're not always asking the questions that you want to know the answers to. And so the interaction that we have with you in trying to understand what the important questions are is a vital part of the research that we're involved in, and a vital part of this adventure that we're all involved in trying to figure out what to do and how to get to a point where we have effective treatments. So another element of this is these again are survival curves for people who have different types of mutations. So here again, the dark ones, the black one up here, are the people who have nulls, that is, they make half the normal amount. And these are people who have different substitutions. So these are the names of different amino acids: serine, arginine, valine, aspartic acid. There are 20 amino acids, but only 8 of them actually are important in terms of considering what happens here. And what you can see is serine, which is the smallest of these amino acids, when it's substituted, looks much more like the nulls. That is, a milder phenotype, a milder clinical presentation with later onset major complications than people who have substitutions by these other amino acids, which are much bigger and which interfere with the function of the molecule, all told. So the advantage of doing these studies is that we begin to be able to say something. Now, we can't say something about you specifically, because this is a population, and we don't know whether you are going to be here, which means you're going to get to be 80, or whether you might be here and have problems early on. And we can't tell that specifically about an individual, but as a population we can say this is what's going on, and maybe we can learn something by studying people who have this and understanding what's going on. So one of the other aspects about things is pregnancy and survival in people with vascular Ehlers-Danlos syndrome. When we started this work a while ago, we were struck that pregnancy certainly could be associated with major problems and problems that non-pregnant women didn't have. So non-pregnant women didn't rupture their uteruses. Their uteruses were small and compact, as they usually were, and there was no impetus to rupturing. But once they got pregnant, there was a very small set of women who had problems with uterine rupture. And if a uterus ruptures, the amniotic fluid gets free, and when that happens and it's in the abdominal cavity, it can give rise to material going into blood vessels and producing all kinds of havoc, and people die from that. The other thing we noticed was that there was a subset of women who, in the peripartum period, that is in the period around the time of delivery, had significant arterial events. So they had aortic dissections, or sometimes they had other arterial ruptures. And in the way that the medical literature develops, each event that occurred like this was reported individually. And then the second event that occurred picked up the first one and said, well, here are 2 examples. And then the third one, here are 3 and 4. And sometimes they got counted more than once. And the result of this was the idea that, well, pregnancy is really a terrible thing to happen, and no women with vascular EDS should get pregnant. And so we were interested in looking at this. And so we, in the group, we had, that we've just put together, Mitzi Murray, who's, as I said, one of our geneticists here, with Melanie Pepin, our genetic counselor, identified 526 women, of whom 243 had never been pregnant. That's what nulliparous means. And 283 had been pregnant. They fell into different groups about the kind of mutations that they had, but they were about the same between the 2 groups. And so we were interested in whether being not pregnant or being pregnant made a difference in survival. It's a very simple question. And here are the answers. So here's the survival curve for the women who had been pregnant. And here's the survival curve for the women who had never been pregnant. And we thought, well, maybe it's because we're looking at just if we looked at the relatives instead of looking at maybe the relatives add something. So we took them out and looked at these are only the relatives and said, well, did the relatives account for this? And you can see even with them, it doesn't seem to make much difference. So this isn't to say that there are not complications in pregnancy. There certainly are. And pregnancy with delivery by vaginal delivery is complicated by vaginal tears and by cervical tears, and which can be quite problematic. C-section limits those, but sometimes there are more problems with that. But what you can see from this is that overall survival is similar. And it may be that what's happening is that pregnancy is simply the opportunity to have a complication that might have occurred otherwise. I'm going to skip that slide. So what do we do about assessment, follow-up, surveillance? Our person with EDS is here at the bottom, named you, I think appropriately. And what we make an effort to do is to provide them to be sure that their primary physician is somebody who's not afraid of EDS, who can read the literature if they need to, who is comfortable talking with us as geneticists who have probably more information about this condition than anybody else, and communicates and gets them in touch with a vascular surgeon so that the person with EDS knows a vascular surgeon, has seen the person, sees the person in the practice, and has made arrangements for what would happen and knows what conditions would stimulate a call to the vascular surgeon or through the primary physician to the vascular surgeon to be sure that that person is immediately involved with a complication that might need surgery. The same is true for a general surgeon. So for bowel rupture, it would be a general surgeon that deals with this. So what are the complications that occur? What are the symptoms? How do you make that decision? And how do you and your primary physician work it out with the general surgeon to be sure that you're going on. And other specialists, so it's that obstetrician, gynecologist, ophthalmologist, which can all be important in terms of taking care of specialized problems. And we remain, as the geneticist, as sort of the overall person who's the go-to person for complicated things. We like to see people on a regular basis and to be able to catch up and make sure that there isn't anything untoward going on. We provide a letter for travel, which details the kinds of complications that can occur, that people can travel with them. The French developed a passport, and we've stolen that from them and translated it into English. It's probably not terribly helpful in this country if you have a passport in French. And I'm not talking about Canadians, just Americans. And we make sure that people have this information available. And we try to do it for people in whom we make the diagnosis in the laboratory as well. And that this is the kind of assessment that's important, the follow-up, and when necessary, the surveillance. And we help people design surveillance protocols. And we're very interested in trying to put together an overall surveillance mechanism for people. So I want to come back and end with something that we hear not uncommonly from people, and that is, I have a little bit of vascular EDS and a little bit of hypermobility. And I think that this is it's a problem. It's a problem in understanding. Vascular EDS is a distinct disorder. It's caused by mutations in the type 3 collagen gene. People with it can have small and sometimes large joint hypermobility. They're at risk for things that are not part of the usual thing that's seen in people with hypermobile EDS. It's important to exclude hypermobile EDS, or to exclude the vascular EDS in people who have concerns about it because of increased bruising or other kinds of complications that might make you wonder about it, so that you know that this is not an issue, and that's always done by genetic testing. So it's an important feature. And these genes are located on different chromosomes. They give rise to different clinical pictures. So vascular EDS is caused by mutations in COL3A1. We usually don't know what hypermobility is caused by. But you can see each gene here has a different name for all these different kinds of EDS. And they are not located next to each other. Each of these is individually relatively uncommon. And so the idea of having two different forms of EDS is, it can happen, but it's extraordinarily uncommon. And so it's important to remember that people with vascular EDS can have small joint hypermobility. They can have large joint hypermobility as well. But the people who have just hypermobility almost never have vascular EDS. So that's a point to end on, I think. And I think at this point we can go to the questions if they're there.
Thank you, Dr. Byers. With some wonderful information, and we'd love to go ahead and go to the Q&A. If you're able to open up that Q&A box and read the question.
So let's see, I open up the box. Okay. What are the basic? So the first question is, what are the basic medications that someone who's diagnosed with EDS, with vascular EDS, should be on? I'm in the UK. I'm with spontaneous mutations, so my family and doctors don't really know this condition. I'm only the second diagnosed in my local hospital, and so forth. I only see a vascular surgeon and a cardiologist, as my vascular surgeon's in control of my care. As many doctors passed until you got to them. I take a pain medication, a variety of other kinds of things. Spoken about a beta blocker, but they say it'll affect my brittle asthma. I'd like to know what the basic medication is. Thank you. Suzanne. So I think this gets to the very basis of the kinds of problems that we have in doing this. First is, are these medications one that interfere with other kinds of disorders? I think in England, celiprolol, which is the beta blocker that was in the study, may be available. It's a fairly specific acting one. I think it has much less effect on asthma. It could be tried. The specific medications, the major issue that we have is to try to make sure that blood pressure is maintained in the normal range. And we don't have other specific medications that are used anywhere except in France, and perhaps now increasingly in Europe, where celiprolol, the special beta blocker, is available. There are some data that are developing in animal studies. I took out all the stuff that we were going to talk about with animal models about things. We have very few animal models, so we have very few medications that have been tested in those arenas. And the medications that have been tried for other forms of aneurysms have not yet been tested in people effectively. So there's no specific answer. I think it may be helpful for you to see one of the geneticists. There are groups in London that see people. Mike Pope is in London and sees people with Vascular Ehlers-Danlos Syndrome. The group in Sheffield sees people with vascular EDS, and the group in Manchester also has people that are familiar with this, and you can see them. So I hope that's helpful. Let's see. Pam asks whether arterial venous malformations in the lung are related to vascular EDS, and the answer is yes. There's a very small set of people that have some unusual vascular malformations in the lung. There are other conditions that also have these kinds of malformations, and they should be always looked at. But yes, there are a few publications of people who have unusual vascular malformations in the lung, which can bleed, and they need to be paid attention to. So the next question is, let's see. When dealing with investigation of bloody stools or in diverticulitis disease, what are the suggestions in imaging? Some of us have been told to get a virtual colonoscopy with air pus to determine unknown cause of bleeding and determine the severity of diverticulitis. So this is a complicated question. The general recommendations about colonoscopy are that it be used only for those times when it's absolutely necessary in order to find the source of bleeding. Bloody stools with blood on the outside of the stools are very often caused by hemorrhoids, which are probably more common in people with EDS, with vascular EDS, because of the nature of the vasculature in the area. Just as they get venous varicosities in their legs, the hemorrhoids are basically varicose veins in the end of the colon and around the anus. So the first thing is to look for hemorrhoids to make sure that that's not the source. It's possible to look in the very end with an anoscope to look to see if you can see vascular abnormalities there. I was surprised. We had two people I saw just within the last month, both of whom had had colonoscopies done in the usual fashion, and both of them survived without problems. There are rare indications and rare publications of people who've had the colonoscope rupture and just go right through the colonic wall. The issue with virtual colonoscopies, as you point out, is that there needs to be inflation. So you need to clear the colon with the medications that clean you out. And then in order to see the edges, you need to fill the colon with air. So I don't think that there are any clear recommendations about how to make it all work and what's safe and what isn't. Using a camera may be helpful. I think it's a matter of trying to determine, how much bleeding, where it is. Bleeding from the colon itself, or bloody stools is not a general part of EDS. And diverticulitis can occur, but we worry that it actually isn't. They're not diverticulae, but in fact they're areas that are ruptured. So is it possible if cancer is not showing signs of rupture has already occurred? Is the wait-and-see approach? So I think I tried to answer that. Sometimes perhaps the camera is the best way to go if you can, if you get clarity with the camera. Let's see. Okay, this is a complicated question. This is a long one. When is genetic testing in order for possible vascular EDS? So, in general, what we've said is, if you're worried about, if the question of diagnosis comes up, then test for it. The testing is pretty straightforward. It involves taking a small tube of blood into a purple top or lavender top tube, and then sending it to one of any of several diagnostic labs around the country. So we have an increasing number of laboratories around the country that are doing diagnostic testing, all of which are excellent. So, so I think it's the issue is if this possibility is raised as a question, it's important to eliminate it. The testing in our hands is a little over $1,000. It's about the same in most other places. And the price for testing will come down. So this is a complex example of somebody who's now at the age of 58 has had a number of different kinds of complications, has high blood pressure. So the age of 58 is, as I said before, there's no specific time when it can't be made. In that situation with so many other kinds of things, the likelihood doesn't seem terribly high, but it certainly is reasonable to think about it and see a geneticist and see what they think. So Ruth from the UK is, can you tell us if issues commonly seen in EDS hypermobility such as gastroparesis, POTS, other autonomic issues are seen in vascular EDS? And the answer is they don't seem to be anywhere near as common. It's surprising that that's it. Have you seen other individuals with factor VII clotting deficiency in vascular EDS? Again, it's we would expect to see them about as frequently as the two would be present in the population. So they're unrelated. They're on different chromosomes. They're not the same. They're not related to it. So Susie says, I'm a spontaneous mutation. Which she says, I have EDS, this kind of EDS, because neither of my parents has it. And what are the reasons this happens and how common is it? Well, about half the people in whom we make the diagnosis are the first affected person in the family. And why does it happen that way? Well, we each have 2 copies of every gene, and in the course of making sperm or eggs, we separate those 2 copies so that we transmit only 1 copy. But every time a cell divides, it has to copy all the DNA in the cell. And the DNA in every cell is made up of about 6 billion different parts. So if there's sequences, the DNA sequences is a simple sequence of 4 different chemical compounds, which we name for convenience A, C, G, and T. And that sequence of DNA is divided into chromosomes. So women have 23 pairs of chromosomes, men have 22 pairs, an X and a Y. Women have 2 X's, that's why they have 23 pairs. And that DNA, each of those strands is anywhere from 40 million to a few hundred million building blocks long, and they have to be replicated exactly. And our replication process is very, very, very good, but it's not perfect. And so every time a cell divides, we have something on the order of one abnormality, or 1 to 2 abnormalities that's left. If that abnormality is in a type 3 collagen gene, then this is what you get. So it's a rare event. We expect it's 1 in 100,000 people or so are represented this way. So can a person with EDS hypermobility pass on other types of EDS to their children, such as the vascular form? And this is from Steve. So each of these, it's a complicated question because one of the issues is the hypermobility that's seen a representation of vascular Ehlers-Danlos syndrome? It usually isn't. So each form of Ehlers-Danlos syndrome is a distinct condition. It's genetically distinct, so the genes are different. So if you have a mutation in the type 3 collagen gene, you don't have mutations in other genes, and so you don't pass on other kinds of Ehlers-Danlos syndrome. So somebody with hypermobility is at the basic background population risk for having a child with Ehlers-Danlos syndrome type 4, which would be 1 in a few 100,000. So it's not very much. Laura asks, what does the gravid uterus mean? That's the pregnant uterus. Let's see. This is a question from Alberta, Canada. The doctors there were not sure how to make the diagnosis. I realize I don't have vascular EDS, but is type 3 also dominant? So the hypermobile EDS is very complicated in the sense that, yes, it does tend to run in families, so that it's often inherited from generation to generation. About 90% of the people that we see with that form of Ehlers-Danlos syndrome are women, and yet it certainly can pass through men. And so it's a little bit like breast cancer. Most of the people who have breast cancer are women, but it's genetic, and in the genetic families, it can pass through multiple generations just in men who don't have breast cancer, who don't get breast cancer, and then have a woman who has breast cancer. So, and that's, can the gene skip a generation and previous children? So again, if there are multiple males in a generation, then often you can not have an affected person and see only the women. Let's see, next. So I'm 27, have small children. My children and I have some vascular type syndromes, but blood testing was negative. And doctors gave us a diagnosis of hypermobility and classical type, but told us it was definitely more. Should we do a skin biopsy? So when we started doing testing, we did everything by skin biopsy. And the problem with that is that in a sense, it's an art form. We had to look at the proteins that were being made. We did it in a way so that we displayed them on an X-ray sheet. And making the diagnosis took a lot of experience, whereas the genetic diagnosis is really very straightforward. And missing the diagnosis from genetic testing is very unusual. It can happen, but it really is a very unusual. So I would say there's a 99% chance that if it's not seen, then it actually excludes the diagnosis. Placenta previa, placental abruption, placental accreta, other kinds of things that are mentioned, stroke, pneumothorax, aortic valve regurgitation. These are things that can be seen, but they're more common in the general population. So I think that this is very unlikely to be vascular Ehlers-Danlos, and that was Adina that asked about that. I have a COL1A1 mutation, inherited my father, thought to have classical type EDS, yet has had intestinal ruptures and brain hemorrhages. Is it possible for serious vascular complications and not have vascular EDS? So COL1A1 is a different gene. It's a type 1 collagen gene, and so I think, Zoe, that if that's the gene that you're actually referring to, and you were tested for vascular Ehlers-Danlos Syndrome. There's a small set of mutations in the COL1A1 mutation that actually do give rise to complications that include vascular problems. The usual mutations give rise to osteogenesis imperfecta, brittle bone disease. So this would be worth going back and talking with the geneticist about and seeing what the story was with that. Next is from Amy. My daughter, now aged 11, had 3 bowel ruptures, 2 spontaneous, 1 as a result of colonoscopy before the diagnosis at age 5 and 6. My test was negative. My sister has thin lips. And then had 2 healthy pregnancies, had a spontaneous pneumothorax. She had cervical thinning with her son. Do you recommend genetic testing for her? So I'm not sure whether the her refers to the sister with the thin lips or the daughter with the multiple bowel ruptures. That's a very early age for bowel rupture with vascular Ehlers-Danlos syndrome. But certainly, again, usually if the question comes up, then we usually recommend that the testing be done. Rosemary says, I was diagnosed by a specialist in another field as having Ehlers-Danlos hypermobility. What do you suggest for specialists? Do you recommend me seeing a geneticist for any type of testing? Again, hypermobility is a complex disorder. There are many different features to it. I think it's worth talking with somebody now that this person, the physician, has moved out of state. Oh, no, you've moved out of state to a different state. I think it makes sense to make sure that your care is being managed appropriately. It's reasonable to see a geneticist, although rheumatologists are often quite good about making the diagnosis. What are your thoughts on somebody with VDS taking ADHD medication? Christina. So I think it depends on whether the ADHD medication makes a difference in blood pressure. So it's worthwhile checking blood pressure periodically, making sure that it's in the normal range. If it really makes a difference in terms of behavior, then that's a very important aspect of life, and but make sure that it's not doing damage to blood pressure. We're often asked if individuals within the same family can be affected by different types of EDS. That is, a mother diagnosed with hypermobility, but suspects that a daughter has vascular EDS, and we're convinced that this can happen. Some medics say not. From Jared. Well, I think one of the things to remember is that some people with vascular EDS have hypermobility and only. So in some of the families that have null mutations, for example, the clinical findings are not very dramatic in people, and often no diagnosis is made, or they're thought to have hypermobility, and then somebody in the family comes and has more severe presentation. So I don't think it's necessarily a matter of having a different type of EDS. It's a matter of what the variation is in presentation. So can I tell you about Jonathan wants to know about the status of vascular EDS by using mouse model studies. So it's been difficult to get exactly the right kinds of mouse models. They're coming into play now, so the medical research is increasing. And I'm hoping that within the next couple of years we'll have much better data from the mouse studies that may help us in identifying particular molecules that may be helpful for treatment. Does transforming growth factor beta play a part in vascular EDS? Certainly, if we thought it would be nice, because there might be good drugs to make a difference. It's certainly one of the driving questions that people are asking now. We don't have a clear answer to it. This betas have been an important factor in Marfan syndrome, and treating the pathways that are involved has made a difference certainly in survival in mice. The recent study in people is not quite as positive about doing it. Here's much, this is from Christy, much debate on losartan or celiprolol. Which is better? Would adding doxycycline help if it added to the regime? Is the current focus of research on vascular EDS on gene therapy or pharmacologic treatments? And any prediction when gene therapy may be the norm? So the last question is probably the easiest one to answer. The gene therapy is sometime incoming. I don't think it's going to be the major form of therapy, and it certainly isn't going to happen soon. The major issue is, one is, could you replace the cells that are abnormal by using stem cells that might make a difference? And they have to focus in the areas where there are problems. The second is, could you use targeted gene replacement? So gene addition by adding another copy of the gene would be difficult because there's still the abnormal copies of the gene. It might make it a little bit better. It's not clear. So I think that for the next several years, at least, the debate or the focus on research is really going to be on pharmacologic treatments, with the hope that the active pathways that are interfered with by having these abnormal proteins can be dealt with. I don't think there are no data on losartan or celiprolol that would allow us to answer the question of whether they would do better. They have very different pathways of action, so we just don't know. Doxycycline is a drug which has been used. Doxycycline is a form of tetracycline, which is an antibiotic, but at very low levels it interferes with the activity of enzymes which chew up the proteins that are outside cells in vessels and other places. That certainly has been tried. It looks as if in mice it makes some difference in the architecture, but it's not clear it makes a difference in survival. Studies are using it in people with aneurysms of other causes, have not been, tetracycline, the doxycycline has not been terribly effective in those settings. So we don't know. They're certainly well worth asking, and I'm hoping that as trials develop, that these will be included. See, my paternal grandfather. This is from Kay. Died at age 70 from an abdominal aortic aneurysm. One just dismissed the fact that he could have had vascular EDS, but didn't consider the fact that my grandfather looked active and did things that a 40-year-old did on an average basis. My uncle is 92, my dad's 82. So you can see longevity my grandfather missed out on. So I don't know. I think the answer is yes, it's possible, but it's unlikely, and that there are many other causes of aneurysms. You ask about smoking, high blood pressure, and I think that abdominal aneurysms at the age of 70 usually have other causes. Steve is interested in why don't we know the genes involved in EDS hypermobility. We ask ourselves that every day when we see people here. It's a very difficult issue. The first is that the fact that it has one name doesn't mean it's one thing. Vascular EDS is defined because there are mutations in one gene. The second thing is that the diagnostic criteria for making a diagnosis of EDS hypermobility are difficult. As I said before, about 90% of the people we see here who have hypermobility are women, and yet we're pretty sure that males have the same genes. They just don't have as much in the way of clinical picture. So being able to track the genes through families is very difficult. For genetic studies, in order to find the genes using our genetic approaches to it, we need to know that if we gather a family together, that and the people who are hypermobile all have the same gene wrong. Otherwise, our tracking is going to be way off course. So all of those things have made it very difficult. And I think the major one is that we think that hypermobility is actually due to mutations in a whole group of genes. And getting people who have the same thing together to be able to do the studies has been difficult. Justin asked, do we see any major similarities between vascular EDS and Marfan syndrome? Could potential treatment for Marfan syndrome lead to treatment for vascular EDS? It's interesting that, in Marfan syndrome, the major vascular regions of vascular abnormality are the ascending aorta to begin with. And as people have survived longer, have had surgery, they're getting involved in other vessels. In people with vascular EDS, the major source of problem is in the medium-sized arteries. So these have very different developmental origins. They come from different cell types. They're created in different ways. So I think that it's I think that they may be quite different mechanisms. So can we have access to the slideshow? I think that's John has covered that.
Yeah, we will be posting those.
Yeah. I'll tell you a little bit about valvular EDS. It's a rare disorder. There are half a dozen people known. It's due to a specific kind of mutation in the COL1A2 gene of type 1 collagen, where the RNA is not made, and people have two affected copies of the gene. They have hypermobility, but they also have multiple valvular abnormalities. It's very rare. We don't know very much about it. Let's see. Are you in contact with Dr. Dietz regarding his mouse models? From Christina, yes. Jenna has a comment. I think it's just a thank you. What's the vascular EDS passport, and how do we get one? We were actually happy to provide them as long as we've done the testing, and so we know that you actually have a mutation. You can contact us. I think you can get us by email. My email is pbyers, B-Y-E-R-S, @uw.edu. If you have a copy of your genetic testing, we're happy to provide a copy of it for you. I'm trying to get a diagnosis, have an appointment with a geneticist. My eye surgeons think with my keratoconus problems my entire life, I might fall into kyphoscoliosis. Okay. I think this is a matter of, I think this is from Janet. I think that seeing the geneticist is the best way to go. Keratoconus is something that can be seen in people with vascular EDS. It can be seen in people with a kyphoscoliotic type, but that diagnosis is usually fairly obvious. And it can also be seen, and probably is seen most often, as an isolated event. So seeing a geneticist is very helpful in that. Why is colonoscopy bad? Colonoscopy by itself is not bad. It's just that there seems to be an increased frequency or risk of having perforation of the colon, and that's not a good thing to have. Another researcher has found that many siblings who test negative for vascular EDS of those with vascular EDS have a lot more hypermobility. Have you found that to be true also, and why would that be? We haven't found it to be true. I don't know why it would be. Could you explain mosaicism? This is from EDS Today. So mosaicism is a feature. Most people who have Ehlers-Danlos, who have vascular EDS, have in all of their cells, there's one copy of the COL3A1 gene that's perfectly okay, and there's another copy of the gene that has a change or a mutation in it. And we talked about the idea of about half of the people that we study have inherited the disorder from a parent who's affected, and half of them represent a new mutation. Well, there's a third group, which is a small group in there, probably represents 5, maybe 7 to 10% of the people who look like they have a spontaneous mutation. There's something new that developed in the sperm or the egg, whose parents have a subset of cells in which there's a mutation, and those cells also reside in the testis or in the ovary, and so when they give rise to sperm or eggs, they can transmit this condition. But because they only have it in a small number of cells, they themselves don't have vascular Ehlers-Danlos syndrome. So that condition of having some cells that are that have a mutation and some cells that don't is referred to as mosaicism. So it's derived from the same idea of mosaicism in tiles and things of that sort. That's a rare reason that you can see recurrence in families. So you can see 2 affected children who are affected, but they don't have an affected parent. In very rare instances, we have people who, well, that's the major reason for that. So, also wondering if your facility does genetic testing, and if you take new patients, live in California, it's easier to go to Washington than back east or to Ohio. So in California, one of the wonderful people to see is Bob Nussbaum in San Francisco. We're delighted to see people. We do genetic testing, and we also take patients in our genetic medicine clinic. Stacy says, back in the 90s, I sent you a skin biopsy that came back inconclusive of vascular type. So, as I said, at that point, it was we grew the cells from the biopsy and then tested the cells for the protein that they make. Our ability to actually to identify people who were making half the normal amount is not as good. It's much easier to determine that they're making abnormal proteins. So testing the blood, testing DNA is something where it either is, we either see it or we don't. If we don't see it, then I think we can conclude that the test is negative. We're not quite so sure with the protein test, so we've actually tried to stop doing them altogether. So yes, testing again is a reasonable thing, if it still remains a clinical question. If you think you don't have the problems, then I think it's not necessary. So KS as an addendum, geneticist thought I had hypermobile EDS from my mom instead of my dad. My dad definitely shows symptoms. Shows some symptoms, I don't know. Okay, so I'm not quite sure what the question is, Kay, but some guys do certainly have hypermobility, and you can see it. So from Janet, another question about having a lifetime of surgeries and restrictions. My mother had similar problems, had stretchy skin. Various doctors at UCSD in San Diego seem to dozens of surgeries. So, sometimes it's working with doctors is an interesting occupation that some of us have, and others of us enjoy, and some people find it very difficult. And I think one of the things that's really very difficult now in the current medical system is that our visits are increasingly short, and for very complex problems, as you outline in what's been going on in your family, it's often very difficult to convey the information in a short time. And and do it. So one of the things to do is to make sure that you organize information before you go. Define the questions that you want to ask. Make sure that you're not overstressing and taking up far more time than the physician has available. If you need to, make sure that you get longer appointments or break them up into a series of appointments to see if that works. And geneticists are really good at this kind of thing because we spend about an hour with each family, so it's a very different experience to see us. So that sometimes is worth thinking about. Ellen asks, are we conducting any clinical trials now? Do I know of any going on for EDS? So the only one that was the major active one was actually the celiprolol trial. It's in France. The drug isn't available in this country. There's an effort to try and get some. That might be something that would happen. I think we're waiting on the next generation of small molecules and the animal studies to know where we should go. When you said there's a small chance of vascular EDS happening in the general population, do you mean that I do not even have hypermobility EDS? One of the advantages of doing this by telephone is that I can't tell because that usually requires a good examination and things, and medicine by phone is not always good. So the small chance of vascular EDS, it's an uncommon disorder, perhaps 1 in 50,000. Hypermobility is fairly common in the population. We don't know how many people have hypermobility EDS as part of that, and we don't know what all the other things that are being associated with hypermobility and how they fit into it. So I don't know how to answer the question. Zoe says, thank you very much, and I have to say thank you to you too. I think we're done with the questions.
Okay. I wanted to ask you one follow-up question. I had heard out on the street from a lot of EDS groups that they're wondering about what the reliability is for classical EDS testing, whether it's worth, trying that or just relying on, their diagnosis in the clinic. So I don't know if you had any other thoughts, to add to that or clarify the testing for classical.
Classical EDS, which is, from a clinical perspective, does have a fairly broad range. But the typical features are a very soft, doughy skin, increased joint mobility, although that can be variable. The skin is often very stretchy, and if you pick up the skin on the back of your hand, you can feel how thin the skin is, and you pull it up. It doesn't come up very far. But that thinness of skin is not something that you feel if you feel the skin on your forearm. There your skin feels much thicker. But people with vascular EDS actually get that thin feeling, and they can pull that surface away more easily. And over the elbows, they can extend the skin or pull the skin out by 6 to 8 centimeters, so a few inches. It's really quite striking. They often have scars on their foreheads, under their chin from when they fell. They have scars and hyperpigmentation in other areas, but it's also quite variable, and some people don't. So when it was first realized that people had mutations in the type 5 collagen gene that was a result of work by several different laboratories around the world, people started testing. And the issue that happened, so Francisca Malfait, who's a very talented geneticist in Ghent in Belgium, did a series of studies on people with hypermobility and what was thought to be classical EDS. And they found that about 50% of people had mutations. That was very disappointing, but what became clear was that they took all comers, and many of the people who were being tested had been seen by rheumatologists or other ologists who didn't know as much about these conditions as the geneticists did. When they went back and they restudied a set of people where they did the clinical diagnosis, they had good diagnostic criteria, they were confident of the clinical diagnosis, more than 90% of people had mutations in the type 5 collagen genes. The study was replicated by a group in Italy as well. So I think the problem of the initial concern was that it really was a consequence of not having the clinical diagnosis very clear. So I think that's the problem. And now I think that the genetic testing is actually quite reliable, and it can be used to basically say, no, you don't have that kind of EDS as well.
Okay, that's very helpful. All right. Well, thank you for all your patience going through all those questions. I know a lot of them were extremely personal and detailed, so it's challenging to sort of sort through some of the detail provided. So thank you for doing that and sticking with us for so long here, almost 2 hours. I am getting a lot of thank yous from the live attendees, and some of their feedback is to say that they have missed you at the last few conferences. You're awesome, extremely informative, and especially reassuring to have access to an expert like you, and very insightful. So just
appreciate all of that. We have had people coming, we've for the last several years, at least one person from our group has gone to the EDNF conferences. So we certainly do make it a point of doing that, and we will continue to do it as well.
Thank you. Well, thank you for all you do for us, and just your care really shines through as we hear you talking, and everybody's just so appreciative, because the words that come to mind are gentle and caring and humble and full of wisdom as I listen to you. So thank you from the bottom of our hearts.
Well, thank you very much. It's very flattering. It's almost as good as being a teenager on the telephone.
Well, we really appreciate you participating in this program. We really needed to have a program like this on vascular EDS. We've been asked for it, and I think people are really going to be appreciating coming back for the recording. The recording will be posted on our site, as well as the slides. So we encourage you to come back for that. If you'd like to get notifications of our sessions that are twice a month, please request the pre-report, and go out to a body support store and look at the items that we have. They're all items that were selected for EDSers by EDSers, and that's what supports this program. So please, you can still get some Christmas gifts out there. And our next webinar is January 6th, so you'll be notified of that. That'll be coming up right after the first of the year. So I want to wish everyone happy holidays, happy Hanukkah, happy Merry Christmas, Happy New Year, and we're going to conclude the session for this evening. So thanks again for your attention, and thank you, Dr. Byers, for a very insightful presentation. So good evening.
Thanks, Dr. Byers. Good night, everyone.
Good night. Thank you very much.